Paige will go first.
Yeah. I don't know if she can start right on time.
Yeah, we're going to start with Catherine now. See without my glasses.
Restaurant.
Part of the presentation. Describing All right, we're going to get started. If everyone could move into the middle seats if possible, so we can leave some seats on the end for the latecomers, that would be great. We're going to do part 2 of our Frail Elderly afternoon focus. So we'll start the session with Dr. Paige Moorhouse again, who was introduced earlier. And then for the second half of our talk, Mary McPherson is joining us via Zoom. Mary Lynn McPherson is a professor and vice chair in the Department of Pharmacy at the University of Maryland School of Pharmacy in Baltimore. And again, like the first part, we will do the 2 speakers, and then we'll have the question and answer shared between the 2 speakers at the end. Thank you.
Okay, I'm back and I know how to work the clicker. Yay! It's the little things. So just as folks are making their way in, I have the same disclosure slide that I had before. At the conclusion of this presentation, what I'm hoping is that you'll be able to describe what goals of care discussions could look like in frailty, to understand the limits and pitfalls of advanced care planning or advanced care plans, to have an approach to just-in-time decision-making, including strategies for patient and essential care partner empowerment, as well as an approach to tough conversations during the health crisis. And these are the CanMed's competencies. So in the first talk, I sort of dealt with items 1 through most of 4, and I'm going to spend all of this time allotment on the skill set needed to approach goals of care and level of intervention conversations with patients and their substitute decision makers or essential care partners. So one of the challenges when we talk about goals of care, it's just similar to frailty really, is that I think we're all sort of talking about slightly different things. And I think oftentimes when we talk about goals of care, especially when I work in the emergency department, goals of care means the code status. It's like, did you discuss goals of care? That means, are they full code or are they DNR? And once you've determined that, you're done. That's all you need to do. And the challenge with that is that, that's not really a goal of care. That's an intervention, right? A DNR status or allow natural death or do not intubate, those are intervention-based designations. Whereas goals of care, I hope, should be outcome-oriented. What is it that we are trying to achieve? And what level of intervention do we imagine might reasonably be able to achieve the patient's goals? So in this presentation, I'm going to take you through 6 steps to addressing goals of care in frailty, and I will start with the first 3. And this will be a case. So Mr. B is 78. He has severe stage COPD. He lives with his wife. He has been in hospital 4 times in the last 3 months with recurrent dysphagia resulting in aspiration pneumonia. And this is despite his wife very diligently following the modifications to the diet that were recommended. And so he comes in yet again with pneumonia, and because this modified diet doesn't seem to be doing the trick, he's made NPO, started on IV antibiotics. The team is considering placing a G tube, but they're quite concerned that with the conscious sedation required, he may require intubation, and if he needed to be intubated, could he be extubated, and what's his code status? So of course they asked the patient, what would you like? And he said, if it will help me live, then do it. So step 1, assemble the decision makers. So I'm going to start with perhaps a bit of a controversial idea, but I'm kind of trying to work through this in my mind, and maybe some of this will resonate with you. I feel like the approach that we have to autonomy in Western medicine is this like all or nothing situation. So if you have capacity for medical decision making, you make the decision, and Everyone else in your family and circle of care, it's none of their business. In fact, if you say, I don't want you to talk to anyone in my family, that's what we do. And the minute that you are determined not to have capacity for medical decisions, now you're out in the cold, and we're talking to a substitute decision maker. And I'm really concerned about that dichotomous approach. I feel like we need something that's a bit more nuanced and takes into account the relational aspects that are inherent in frailty. And one of the major problems with this, of course, we've already discussed, and that's that capacity is routinely overestimated, especially for the kinds of complex medical and surgical decisions that are required in frailty. And I think in some ways it also serves us, because it kind of absolves us of a stake in the outcome, where we say, well, my job as the clinician is just to make the diagnosis and bring the options to you. I present the options and you choose among them based on your values, and whatever the outcome is, well, that's kind of on you because you made the decision. And I think that what we fail to really recognize is the false equivalence that's created when we merely bring options to the patient and their essential care partner. So if we say, well, you have this disease and we could do this or this or this, I think inherently, especially if you have low medical literacy, it's implied that all three of those are reasonable options, and perhaps that they're equally reasonable options, and that it's just a values-based decision to choose among them. When as a clinician, you may have, experience or a very strong inclination or recommendation about what might help best achieve the patient's desired outcome. And as we said before, the kinds of patients that we see in frailty are really woefully underrepresented in the literature. And so it does require us to extrapolate. It does require us to draw from our experience in addition to the scientific literature to help make recommendations and help with decision navigation. So getting back to Mr. B, he has a geriatrics consult, delirium is diagnosed, and sort of retroactively, it's recognized that this gentleman had issues with cognition that are consistent with a mild stage dementia prior to his presentation. He lacks insight into the diagnosis, and I must admit, we had a fellow a few years ago, Donald Dole was his name, and we had this Dole principle that he created where he said, if you ask a patient if they have problems with their memory and they say that they do, they're probably fine. But it's when they say that they don't that you really need to worry. And I think that is, it's not perfect, right? But in many ways it is true, because lack of insight into the cognitive changes is one of the first features of dementia. So this gentleman lacked insight into his diagnosis, exceedingly common in dementia. And I put this in the case to just demonstrate to you that if you have dementia, but you lack insight into that diagnosis, you're not willing to sort of engage with the notion that you have it, this has an impact on your medical decision-making for every other health issue that you have, right? Because you have a chronic, progressive, ultimately terminal condition that affects how you respond to all of the other treatments. So I just put that in there to help remind me to sort of make that point. So Mrs. B, his wife, is identified as the decision-maker, and she says, I want everything done. And as often happens in medicine, when someone says, this is what I want, and we're like, I don't know about that, the approach was to, let's just ask her again. Someone else will go in and have the conversation. Let's see if we can get a different answer. Maybe we present it a different way. So she was approached a couple of more times. And as often happens, this really galvanized her to her position. She sort of withdrew from the conversation. She said, I don't know why you people keep approaching me. I told you what I want. We're done. And I'm sure all of you have heard versions of that sort of in your clinical practice. So that really brings us to the burden of decision-making. And this is something that I think, particularly when it comes to substitute decision makers, we really underemphasize. So, a big part of advanced care planning, for example, is the appointing of a delegate. But we often sort of fail to ask that delegate, are you comfortable with this, with this role as decision maker, particularly when they're sort of the default decision maker, such as the spouse of the person. And so we know from the literature that substitute decision makers report a lot of confusion, a lot of uncertainty, and a lot of guilt. If I make the wrong decision, then the outcome is, it's all on me. They're often struggling to reconcile where there is an advanced care plan, what was said in the advanced care plan versus the current context. they're often receiving multiple and usually conflicting messages from different members of the healthcare team or different subspecialties, and they're often tolerating or accepting suffering on the implicit promise of recovery, like we talked about before. And I think all of this can really result in a substitute decision maker taking the position of advocating the intervention as opposed to advocating for the outcome. I also want to point out that, and I said this before, just because you have dementia doesn't mean you lack capacity for decision making. But in many ways, the opposite is also true. Just because you don't have dementia or delirium doesn't mean that you're actually able to assemble all of the information and demonstrate an appreciation of that information and its application to the situation. So we know that when stakes are high and emotions are high, that this can impair executive function, which is a key element of that decision-making process. And this can result in what someone called, not me, please don't put this on my evaluation. I didn't make up the term maladaptive coping, but that's what it's called. So this is where people are struggling with that role as a substitute decision maker, and they're sort of withdrawing from the conversation. They don't want to talk about it anymore. And one of the complicating factors with this is that we never assess the capacity of the substitute decision maker, right? We can't do that. She's not our patient. We have no. But what I do say when I'm doing these complex assessments and we're concerned about the decision maker's capacity to engage with the conversation and hear the information and make an informed decision, is that it's our duty as providers to ensure whoever is making decisions on that person's behalf has capacity for informed decision making. So although we might not be able to do sort of a formal capacity assessment, if you have concerns, unlike Mrs. B, she said, we're done. We're definitely not done here, Mrs. B. We need to do a little bit more. So step one, assemble the decision makers. So my first tip is that regardless of the patient's capacity, so for all of us in the room, okay, who presumably have capacity, I'm going to make that assumption, all of us should have a delegate who we consider to be our decisional understudy. Not just a delegate, but a decisional understudy. So if you were part of a summer stock theater company and they were doing, Hamlet, and you didn't get the part of Hamlet, but you were the understudy, they don't say to you, run along home, we'll call you on that night. If Hamlet is sick, you come in, you do the play, everything will be fine. Because they know that you need to learn the lighting, you need to learn the cues, you need to learn the lines, you have to be able to take on that role, and they need to prepare you for that. But that's exactly what we would do with substitute decision makers. We sort of say, run along home, it's none of your business until this person loses capacity, and then we'll pull you in the middle of the healthcare crisis, and you can make the decision without any benefit of context or prior conversation. So I always insist that people have a decisional understudy, and when they tell me, I don't need anybody, I'm going to make all my decisions in advance so we won't have this problem, I see that as an opportunity to address a gap in understanding, right, about how decisions get made when people lose capacity or sometimes in progressing through the stages of frailty. So also the tip is that in circumstances that have a high potential for high emotions or maladaptive coping, I actually request that the substitute decision maker bring a decisional understudy for them, right? So you have Mr. B, he's in the throes of acute illness, his wife is, really upset. I ask Mrs. B, is there someone else who you could bring with you to the discussion to just hear the information and maybe help you sift through it? And I call this the brother-in-law phenomenon, right? Because it's, the person's just sort of 1 degree of separation removed from the intensely emotional situation. They may know and hopefully know the values of the substitute decision maker and the patient and can help them navigate through. And the other tip is to acknowledge the burden of this role. Many people have this role without ever signing up for it, and many people who did sign up for it had no idea what it entailed when they were signed up or volunteered for it. So Mr. B, is there someone else who could help with decision making here? So Mrs. B identified Mr. B's daughter, their daughter. And when we spoke to her, she said, I know they're both terrified of death. He doesn't want to suffer. He would be devastated if he couldn't go home again. And she also said, and I'm sure you've all heard this many, many times, I can't make the decision between life and death for him. So step 2, that brings us to step 2, which is to provide information, which is, the tell of the ask, tell, ask model. So you're going to describe disease stage and progression. Then you're going to overlay on that dementia stage and progression, And then you're going to overlay on that, pulling this all together. Your father has not one, but 3 chronic, progressive issues, all of which shorten life, but taken together mean that he is frail, right? So you're pulling it all together. You can use the frailty cycle as a way to kind of describe that acute health crisis and the incomplete recovery, and even tap into whether they've noticed that each time he comes home from his aspiration pneumonia, he's not quite the same as he was before. I often use the phrase, he is in the last chapter of life. I cannot say how long that chapter will be, but I want to ensure that during this time, we choose the treatments and interventions that are going to best support his values and his quality of life. And I also talk about what is certain, and we talked about, the acute health crisis, challenges with complete recovery, and clarify non-decisions. So here, Mr. B's daughter is expressing to us, and oftentimes people feel this way but don't express it, that she's like in this position of making a life or death decision, when really this isn't a life or death decision. This is a decision about what the last chapter of life is going to look like. So I find it really helpful to explicitly kind of relieve that burden and say, you're not making a life or death decision here. We're just talking about what the last chapter of life looks like, and obviously checking for understanding. So coming back to the frailty levels, and we said that the dementia stages map onto these frailty levels. We'd say, your father has mild stage dementia. In mild stage dementia, you might notice that he needs help from you for things like, driving or making banking decisions, etc. Dementia progresses over time in stages. The next stage of dementia is called the moderate stage, and that's where he would need reminders from you to bathe or dress on a regular basis, for example. So just sort of describing current stage, next stage, and depending on the variety of dementia, I would describe sort of typical dementia, Alzheimer's, vascular, some mixture of the two. Each stage of dementia lasts about, 2 to 3 years, depending on the person's progression. So some words to use there. And again, coming back to the frailty cycle and this notion that this acute health crisis can take many months of gradual decline and kind of push them into one acute health issue or health episode. Step 3, clarify priorities. So before you make any recommendations, if you have them, you need to understand that hierarchy of priorities for well-being that the patient has and can express, or perhaps their substitute decision maker is trying to kind of sift through and describe on their behalf. And we talked about some of these in the first session this morning. Maybe it's symptom control. Maybe it's the location of where they're receiving care. Maybe it's that they want to survive to see a really important upcoming event. Maybe it's safety and risk. Maybe it's longevity. But in frailty, what is certain is that decision makers will need to choose between those priorities. At some point, achieving priority A will be in direct conflict with what's needed to achieve priority B. So maybe, care design for longevity is involving discomfort or living at risk in order to be in the preferred location. And I think it's really important to help the person and their decisional understudy kind of understand that at some point these priorities and how to satisfy them is going to conflict with one another. So in the discussion with Mr. B's daughter, we provided information and recommendations, including the phraseology, he's in the last chapter of life by virtue of his severe stage COPD, but he also has, dementia, which progresses over time, and clarified that these are not life or death decisions. We also use the frailty cycle to sort of describe that recovery from each subsequent aspiration pneumonia will deliver him to a state of worsened health, a new functional baseline. And they had experienced that prior to this conversation. A focus on quality of life and symptoms is appropriate. I'm not saying that's what we have to do, but just introducing it as a viable and appropriate option. So the discussion led to his daughter saying, the priority here, we really want to get him home from hospital. I don't think a G-tube is what we want here. Could he have his morning coffee, because that's so important to his quality of life? Could he have that at risk? And we had a discussion about that. So remember, we're talking to Mr. B's daughter. She's not even the official decision maker, okay? But she is supporting her mom, who's having difficulty coping and has kind of withdrawn from the conversation. So we brought all of this back to Mrs. B, who agreed. She said, what my daughter said makes perfect sense. And I know you've encountered that before, where you can sense that someone is uncomfortable in their role as a decision maker and they're really looking for help and support with that. So that brings us to item 4, or number 4 on the list, which is determine which physician, decisions, not physicians, can and should be made in advance. And certainly I would say that not all decisions can or should be made in advance. So how do we figure that out? We're going to take a little sidestep for a minute in this very short case. This is Mrs. P. She's 75. She had a left total hip arthroplasty 8 years ago. Unfortunately, the hardware became infected and she required multiple revisions of this surgery, including incision and drainage and chronic suppressive antibiotics. She lives at home, walks with a walker, but has chronic pain in that hip. She goes to see her orthopedic surgeon for her annual visit, and the plain films show that the hardware is failing. He says, look, I can see this hardware is failing. I think we need to take you back to the OR and do another revision. And she says, and I quote, under no circumstances am I willing to go back to the OR. Been there, done that, I'm done. What I have right now, that's what I'm going to have. And her orthopedic surgeon was amazing. You know, he documented all of this in the consult letter. 2 weeks later, she fell at home and fractured the hip and developed delirium due to the magnitude of analgesic medications that were required for her pain control. The options at this point, because of the fracture, were disarticulation of the limb or palliation. And the team had approached Mrs. P multiple times and said, Mrs. P, we've got to take you to the OR. We need to fix this hip. And she said, no more surgery. But they were concerned that, she was delirious and didn't understand. And that's why we were called in to see her. So here we have a woman who, and I'm just for the sake of argument, let's just say she was cognitively intact. There's no history of dementia. She had capacity when she went to see her orthopedic surgeon. She had lived experience with a health issue, a pertinent health issue, the operating room, the recovery from that. She knew what that looked like. She made an informed, specific directive that was documented and available to the team and made just 2 weeks prior to this incident. She's checking all the boxes for a good advanced care plan. But when her delirium cleared, and we made a few suggestions to see if we could get it to clear up, we had a conversation with her, and she said, of course, take me to the OR. I don't want to die of this hip. I'm not done living. So the decision was the complete opposite of what she said. What went wrong here, and what could we do to try and avoid this kind of situation? So before I get to the remedy, I do want to point out, at least in Canada, if you look across the country, province to province, there are some provincial initiatives to help patients develop advanced care plans. And they generally focus on appointing a delegate and advanced decision making. But when I look across the country, these initiatives all lack any assessment of the patient's capacity or cognition as part of it, or any information from a physician or any guidance or navigation from a healthcare provider to help them understand their health issues and how they might change in the future. And what's also lacking is any kind of caution about making advanced decisions. In fact, and I'm not picking on BC, but this direct quote from the BC My Voice Advanced Care Planning Guide, by planning in advance, you can be sure that your family, friends, or healthcare providers know your wishes and can ensure these wishes are followed. I mean, that reaction says it all. I think that's a great sentiment, but it's just not reality. And I'm sure everyone in this room has lived the perils of the advanced care plan, especially when we encourage people to make specific decisions about interventions or, I don't want to go to long-term care or, whatever the case might be. So how can we get the most out of advanced care planning? Well, first, I think a cognitive assessment or an assessment of the person's capacity does need to be a routine part of any advanced care planning, any goals of care discussion, or any discussion where a major medical or surgical decision is going to be made. I think we need to be more open about the limitations of advanced care plans, and we as healthcare providers, I think, should be influencing some of these provincial programs and the wording, the way we present this to the public. And I would also suggest that we use something that I just made up called the bucket approach. Here it is. So how to make decisions in advance. So we've established the delegate, okay? We've involved the delegate, the decisional understudy, okay? And we've established, what are the priorities and when they understand that these might conflict over time. But if we're talking about specific interventions, we're going to use the bucket approach. So there are 2 buckets. Everyone has 2 buckets, a green bucket and a red bucket. In your green bucket are all interventions that would be appropriate, medically, culturally, religiously appropriate for you, given those considerations, your frailty and prognosis, okay? In the red bucket are interventions that would be medically or, again, culturally or religiously inappropriate for you, okay? Could be reasonably refused on those grounds. So over time, as we become more frail, we're moving these interventions from the green bucket into the red bucket. For most of us in this room, there's probably, nothing that would be in the red bucket initially. But as we move through frailty, various interventions are going to move into that red bucket. They will become medically inappropriate in the terms that they would not reasonably, foreseeably help achieve those goals that we have laid out. Okay, so we talked about that. All right. So this is the bucket approach, okay? So Mrs. P, if we come back to that case, she stated a preference. It was an informed preference. She had capacity for that. But her arthroplasty still would have been in the green bucket. It was still medically or surgically appropriate for her to have arthroplasty. The reason for her refusing it in advance was that she couldn't possibly imagine going through that again, okay? And so that's the kind of decision that we wouldn't advise people to make in advance, or at least I wouldn't advise people to make in advance. So that brings us to number 5. If we shouldn't be asking people to tie everything up in a neat bow and make all decisions in advance, what should we be doing? We need to have a plan for just-in-time decisions. Let's talk about that. So the first thing that we need to do with just-in-time decisions is that we need to empower decision makers with information gathering skills. We've talked about the importance of having that decisional understudy. So when we're empowering people, we're not just empowering the patient, we need that decisional understudy in on the conversation. We need to build skills in both of those individuals. And we need to provide real-time support for the health crisis. So what can this look like? Mrs. A, 83, congestive heart failure, chronic kidney disease, COPD, diabetes, comes in with pneumonia. She reports she lives alone. She's independent with all her activities. She develops chest pain while she's admitted for pneumonia. She consents or assents or doesn't disagree with cardiac cath, which finds 3 vessel disease. Then she develops a GI bleed with the anticoagulation and has a colonoscopy. And then she develops delirium, and the team is considering CABG as the standard of care, bypass surgery, and they're a little bit worried because she's delirious. So they consult us. And we pick up the phone, right? So we call her daughter, who's hearing from anyone in the hospital for the first time since her mother has been admitted. And she reports some cognitive and functional changes consistent with baseline moderate stage Alzheimer's dementia. She says, don't worry, my mom has an advanced care plan. I'll find it, I'll bring it in. It was completed 3 years ago. It appoints her daughter as the substitute decision maker. It says that Mrs. A wishes to be full code and that she wishes to avoid long-term care. So we have a few challenges now, right? We've missed her capacity, certainly this admission, and who knows, when she made the advanced care plan, we don't know what her capacity was then. But now we have an advanced care plan that doesn't really reflect or jive with the current context, and a daughter who's struggling to kind of reconcile these two in the middle of a health crisis. So we need to build skills in the decision maker so that when they are in that acute health crisis, they know how to gather the information that they need to help them make a decision. We can't predict the specifics of every possible health crisis in frailty, but the biggest step we miss is step 2, which is providing information. So in our clinic, we spend time with the decision maker and the patient working through a series of questions that are designed to help them gather that information during the health crisis. And we put them on our card so that we say, keep this in your wallet. When you're in the emergency department, you're not sure what to do. I want you to pull out this card and work through these questions. And in fact, we work through the questions with a hypothetical situation. So for example, in someone with severe stage dementia, we might work through the scenario of a hip fracture. So let's come back to Mrs. A. Which health conditions are easily treatable, which are not? Her 3 vessel disease is, I won't say easily treatable, but she has several other chronic progressive conditions that will not be helped by that intervention and in fact could be made worse. How will frailty make treatment risky? We've talked about some outcomes related to frailty in the literature in relation to bypass surgery. How can symptoms be safely and effectively managed? Well, it isn't the standard of care for her, but what if we could explore PCI as a lower risk alternative? Will the proposed treatment improve or worsen function or memory? Certainly bypass surgery in the setting of moderate stage dementia poses a major risk to someone's cognitive baseline. The emergence of behavioral symptoms in hospital, and it also poses a risk to them being able to be discharged, back home or to their location of preference. Will it require time in hospital? Certainly. If so, for how long? It could be quite a long time in moderate stage dementia, moderate frailty, undergoing a major surgery. Will it allow more good quality years, especially at home? Well, one of the reasons that bypass is generally the standard of care over PCI is the increased longevity of the grafts, right? But in the setting of Mrs. A, with her chronic progressive issues outside of her coronary artery disease, it's not certain at all that bypass is going to give her more years of life, and it's certainly in question whether they'll be of good quality. And what can we do to promote comfort and dignity in the time left? So she receives her PCI and she's discharged home. She recovered incompletely from her delirium and needed more help with her basic activities of daily living. So heading more into the severe stage of dementia after hospitalization, whereas previously was the moderate stage. She came to the emergency department 6 months later with sepsis. A large mass was detected on a CT of her abdomen, as well as a large fluid collection. Surgery, bless their hearts, they noted her frailty and they said no surgery. But what they did say is that let's give her IV antibiotics for this abscess. And her daughter is there, there's other children flying in from all over the country, and her daughter's looking for advice on what to do. So my next tip is, before you go into that discussion about what to do, it's really important to kind of prepare yourself. Take a moment to prepare for the discussion. And that includes, and we sort of talked about this at the break, acknowledging your own values, bias, your own trauma, your own lived experience with end of life, because that certainly, plays a role. It's sitting at the table with you in that meeting. Reflect on the individualized risks and benefits before presenting options. You might consider playing out, well, what's the best case scenario? What's the worst case scenario of this proposed intervention, particularly for people with asymptomatic conditions? What's expected? And is there a decision to be made? If so, is it a life or death decision? So just providing a bit of context to the decisions. Be curious about your reflexive plan. When you have patients on your unit who aren't responding to their expectations for recovery, those folks need a second look. I think as an internist myself, we all have a tendency to sort of micromanage in the face of deteriorating overall health and just like, oh, well, fix the anemia and the thyroid indices and all, but we never take that step back. Have we tallied the total pain that we talked about in the first session? And really lean into the difficult family, right? To explore what are the drivers of their preferences. What's contributing to that gap? Do we all have the same set of expectations about what's going to happen? And particularly with children who are, living away, they may not have as much familiarity with some of the functional issues and the dementia as an adult child who's living in the same city. Have they had prior experiences with serious illness and death? Is there mistrust of the medical system? And is there denial and challenges coping? I just was going to give this very quick example of a gentleman that I saw who was in the ICU. He presented with a heart attack and ended up on dialysis and intubated in the ICU, wasn't responding to treatments. And his daughter said, "You've got to keep going. You have to keep going. Just do everything." And eventually the ICU team consulted us to talk with her. She said, "I know why you're here. You want me to turn off all the machines. And I'll tell you right from the beginning, I'm not going to do it." We said, well, that's not really what we want. We just want to understand what's going on here. So we had this prolonged discussion about her experience with her dad. She said, my dad was a terrible, horrible man. And I'm worried that if I don't pursue these treatments, he will not have the opportunity to wake up and repent for his sins before he dies. Which suddenly it's crystal clear, right? Suddenly there's that opportunity for alignment. And we said, well, maybe as his daughter, you could repent for his sins on his behalf. Is that work that you feel you could undertake? And she was able to do that. But it's only through exploring those drivers that we were able to get there. So support during the health crisis. First, embrace your role to shoulder the emotionality that inevitably comes with grief associated with the acute health crisis. Suddenly, the implicit expectations for the future are in question or in peril, and people are often very, very upset during that time. And part of our role is to shoulder that emotionality. And I think, as we've all experienced in your roles in palliative care, that acute health crisis brings family members and a whole lived experience and dynamic to the surface. Lived experience and trauma, the family dynamics, the things we think but do not say, and existential questions and fears. And, as clinicians, we need to be ready to kind of dive in and explore those. And I think the other thing, and I originally sort of put this slide together when I was doing a presentation for internists, and I sort of said, like, the events that constitute that last chapter of life, particularly the transition to death, are such a huge part of how the survivors see that person's legacy, their own identities, how they'll respond and approach the next end-of-life experience in their lives, and it will create a story that influences how they approach, illness and dying for forevermore. And whether we like it or not, we are helping them craft that story, whether it's intentional or whether it's by omission. So, So tips for this, again, be consistent, explore the team's expectations. Don't just stop at sort of your understanding of frailty and meet with a family. You got to meet with the whole team, because otherwise that boost is going to show up on the meal tray every day, and the poor daughter is going to think, well, if I don't encourage my mom to drink this boost every day, she's not going to recover. Or the physiotherapist may continue to come in with saying, Mrs. Smith, you've got to get up or you're not going to go home, and poor Mrs. Smith may not be going home and may not be getting better, and how could we use her time and energy in a more patient-centered way? Be patient. It takes time for families to grieve in order to engage with these discussions, and be a navigator for shared decision-making. And of course, you're all familiar with the shared decision-making model. But I think just to highlight that when we see maladaptive coping, when people are withdrawing from the conversation and don't want to kind of hear the information, this is an opportunity to be more intentional and discreet with the options that we offer, and really a place to provide recommendations where we have them. And this is not grounded in paternalism for paternalism's sake. It's grounded in compassion and humility. So we met with a family and we reviewed that surgery had said surgery was not recommended or being offered. But we also went through the IV antibiotics, which would be easy enough to just sort of say, oh, well, what's the harm in that? But the best case scenario for Mrs. A is that it would extend her life in hospital. She can't go home with her IV antibiotics, and that she would achieve a new baseline there. And we all know that IV antibiotics are not going to eradicate a large abscess. It's a bridge treatment, but in this case, it's not leading somewhere. The worst case is that it could lengthen her period of suffering and hospitalization prior to her death. Her family requested time to discuss this, and we really sort of said, if there's anyone around the table who is struggling with this decision, we want to hear about it. Like, this is the time to discuss it, right? And we recommended a focus on comfort and demedicalization, including following up with the general surgery team, her charge nurse and nurse physiotherapy, et cetera. So the last tip that I'll provide is practice. It really bothers me because, you wouldn't just say to someone, well, if you have a minute while you're in that patient's room, they have appendicitis, you just whip out that appendix and be like, I'm an internist. I have no business or training in how to take out an appendix. But I think the procedural skill set that is required for effective care planning is equally specialized. It requires equal amounts of practice to build that skill set. And it's not always practical in an inpatient or busy specialized unit to do this. So instead of feeling like, well, why didn't the cardiologist address those goals of care? I think I feel a lot better these days in my practice saying, of course, I want them to focus on the cardiology issues, and we'll take on the broader goals of care. So pulling this all together, we're going to assemble the decision makers, including insisting on a decisional understudy. We're providing information, eliciting priorities. We're determining which decisions can or should be made in advance, those ones in the red bucket, okay, and providing recommendations where we have them, as well as having a plan for just-in-time decisions. And finally, we're going to document it. And I won't spend a lot of time on this because you have a copy in your slides, but recently I had the opportunity to co-lead an initiative for our province where we wanted a better approach to goals of care. And what we decided as a group is that if we made the form a little bit better, it might sort of encourage people to add a bit more context and color to the goals of care documentation. And so we were very diligent about including elements that might not typically be on here. For example, what was the reason for this conversation? Is it just future planning? Is there an acute health crisis? Is there an admission? Is something else going on? What are the patient priorities? We also, in the various levels of intervention, so the sort of outcome of the form, provided a patient perspective. How would the patient describe each of these levels of care? So for example, C2, which is purely comfort care, keep me comfortable and do not delay my death, which is different from C1, which is I accept treatments, but not at the expense of my immediate comfort. And which kinds of treatments and interventions would, wouldn't, and may, depending on the context, be provided in that situation. So kind of framing it out that way. We also provided on the back of the form some cues, again, for non-geriatricians, non-palliative care providers to think about the burden of other chronic progressive disease that this person may be encountering and how their function had changed over the last 6 months. Had they had visits to the emergency department? What was the sustainability of their preferred living arrangements and care? and also left a lot of free space for them to describe the conversation and who was there. We also put this QR code on the bottom, which leads to our library guide, so that physicians who never use the library guide could at least scan it on their phone if they're looking for additional resources. So those are the steps. In summary, obviously, goals of care conversations in frailty are complex. Ensure your understanding of that person's baseline is accurate and that it is front and center, including their cognitive baseline. Integrate the concepts of suffering and incomplete recovery into discussions where the patient or the substitute decision maker is making choices about treatment, and advocate for functional outcomes and measurement of frailty in any study in which you're participating. And finally, explore and practice the underappreciated roles of the physician or clinician as interpreter, mediator, negotiator, navigator, and guide. And if anyone is interested in more information on the PATH program, there's a link there. Thank you.
We're just going to have Professor McPherson join us via Zoom for the next part of the talk, and save your questions till the end or type them into the Q&A, please. Thanks.
Hello, I'm ready to roll, but someone needs to enable my ability to share my screen. Can you all hear me, I hope?
Yeah. We can hear you.
Okay, I just need someone to enable the Zoom so I can share my screen. Okay, now we're cooking with gas. Alrighty, so my name is Lynn McPherson, as you heard, and I'm a professor at the University of Maryland in Baltimore, and I'm the executive program director of our online graduate studies in palliative care, where we have 5 graduate certificates, a Master of Science, and as of last year, Doctor of Philosophy degree in palliative care. And I do practice in hospice and palliative care. So the title of my presentation is Deep Prescribing for the Elderly and in Advanced Illness. I have nothing to declare. Whoops. My learning objectives are, we're going to talk about a systematic approach to deep prescribing in those who are older adults and advanced illness. We'll talk about deep prescribing in metabolic syndrome and Alzheimer's disease. And unfortunately, we probably won't have time to get to the last one, but you've got the slides on deep prescribing and anticoagulation, which I think is one of the most difficult decisions to make of all.
Professor McPherson, I'm just going to interrupt you. Do you have the right screen that you're sharing? Because we're seeing a blank screen at the moment.
Yeah, let me do it again, but yes, I am. Let me try it again. Do you see the deep prescribing slides now?
No, we're just seeing a black screen telling us that you've started sharing.
Let me tell the IT people. I'll try it again while what do you see now? Still the black screen?
No, it's basically grey. It's almost like your desktop.
I don't know what to say. I'm selecting exactly the slide presentation. It must be a technology error. Still the same?
Yep, nothing's changed.
Okay, well, why don't I just talk and then hopefully the IT people can provide some insight. So first thing is, what is polypharmacy and why should we care about it? So the literature provides several definitions. Is it a patient taking 2 or more drugs at the same time, 5 or more, 9 or more? And I also had a pharmacy student once who thought polypharmacy meant a patient who went to more than one pharmacy. And I could kind of get behind that one. But generally, the accepted definition is someone taking 5 or more medications concurrently. So
Professor McPherson, would you be able to email the IT people your slides? Because then we might be able to bring it up.
Sure. Do you want to type your email in the chat box, IT people?
That's great. Thank you.
Sure. All right, they're on their way.
In the meantime, you can continue and we'll get the slides up as soon as we can and I'll let you know.
Alrighty, thank you. Alrighty, so if you look at the prevalence of polypharmacy, at least in the United States, from 1999 to the year 2000, it was about 8.2% of the population. But if you look at a decade later, it was up to 15% of the population. And if you look at polypharmacy in long-term care, 91% of the residents were taking more than 5 medications, 74% taking 9 or more, and 65% taking 10 or more. That is a lot of medications. And we know the consequences of polypharmacy: frailty, dementia, cognitive decline, disability, hospitalization, and increased mortality. And then when you consider, that's pretty much in older adults, when you consider superimposing an end-of-life illness, we've got the issue of all the side effects that they may have, plus the cumulative anticholinergic burden, the sedation burden, disease-associated and age-associated pharmacokinetic and pharmacodynamic changes. So you would think that as people approach the end of the road, that they would be taking fewer medications. But sad to say, this is not the case. Data has shown that average results showed during the year before death, the percentage of patients taking 10 or more medications increased from 30% to 47%. That's insane. A retrospective study of over 500 older nursing home residents in Sydney, Australia, looked at the changes in prescribing of both symptomatic and preventative medications in the last year of life. Overall, there was not a big change, and we did see a slight increase in symptom management drugs and a reduction in disease prevention drugs. But at the time of death, interestingly, 1/3 of the patients had actively prescribed antithrombotic agents, antihypertensives, and osteoporosis medications. And I think this last fact is the one that just I can't believe. 179 patients in the last week of life in either a hospital, a hospice, or at home in the Netherlands. They looked at the mean number of medications used per patient, and it was 9 on day 7 before death. So they were taking 9 different drugs a day, 1 week before they died. And hold on to your hat. 30% of these patients received a preventative medication on the day of death. Good grief. What are we trying to prevent? So if polypharmacy is the problem, what's the solution? Well, some people call it the geriatrician salute. Some people call it medication de-intensification, and most commonly we refer to this as deprescribing. Deprescribing is defined as the process of withdrawal of an inappropriate supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes. Now, here lately, I've been calling this goal concordant care. It seems like deprescribing has a bit of a negative connotation. So if we can prescribe in conjunction with the patient's goals of care, as our previous speaker said, this is a win-win. So surveys of patients and of prescribers, let's look at that data. If you look at patients, survey after survey has shown that the vast majority of patients said, I would be okay cutting out 1 or more of these drugs, particularly if my prescriber agreed. So whether that's in the community or in a long-term care facility, one of the largest studies was done by a researcher from Australia looking at Medicare beneficiaries in the US. She surveyed about 2,000 people and asked to respond to the comment, if my doctor said it was possible, I would be willing to stop 1 or more of my regular medicines. 92% strongly agreed or agreed. So people are on board with this. What about the prescribers? Well, physicians are generally certainly in favor of this. 75% report they have general confidence in their ability to deprescribe, including preventative medications, and about half are comfortable stopping a guideline recommended medication. 50% are reluctant to discontinue a drug started by a different physician. Doctors said they were uncomfortable stopping a drug where the patient or the caregiver wanted to continue the medication. So there are a lot of barriers here. So how do we go about deprescribing? Well, there are 3 approaches. One is a model or framework, which is an approach to decisions. It's kind of like a way of thinking. So this is where we have to consider many variables, like what are the patient's goals of care? What is the time to benefit of the medication? So if we have someone who's terminally ill and we're thinking about starting a medication, you have to ask yourself, how long will it take to see the benefit of this drug? So for example, if you have pain and we give you more, half an hour, that's great news. If you have ASCVD and we start a statin, that's going to take several years for you to see the benefit because it's more of a preventative medication. Also, we look at the life expectancy. Another thing I look at is the legacy effect of medications. When we talk about metabolic syndrome, I'm going to be talking about the legacy effect. One example is osteoporosis. When someone's taken a bisphosphonate for 5 years, for example, and then they stop the bisphosphonate, there was no increase in fractures here. So sometimes we have this legacy effect. So very important. Now, honing it down a little bit more, we can look at the whole medication list. And certainly we have to take into consideration the patient's clinical status, considerations for assessing whether or not you can deprescribe. Then you come up with your list of meds that you're thinking, maybe we will deprescribe.
Excuse me, Marilyn. We
Yes.
do have the slides up, but we're not sure which slide you're on. We have number 9, I think.
I'm on number 10 right now.
You're on number 10, perfect. Just let us know, just ask us to go to the next slide and we'll do that for you.
Thank you. All right, so we're on slide 10. It says, let's do this. Okay, how exactly do I do this? And last, we have guidance that is medication specific. So detailed guidance on deprescribing an individual medication, whether it's a proton pump inhibitor or an anticoagulant or whatever it may be. So it assesses whether that specific medication can be deprescribed. And it's important to know how to deprescribe. So do we have to tape? Can we stop it cold? What conversations should we have with the patient and the family? And most importantly, what do we monitor after we've stopped one or more medications to see if the patient has a rebound in their clinical status for which they were getting the medication? Next slide. So you should see the thinker on this slide, the model or framework. So again, this is kind of like the 20,000-foot view. It's a high-level model or framework for making these decisions. And I think it's a shift from caring for people who are not elderly or are not living with an advanced illness to that mindset. The example I can think of is when I have a pharmacy student orientation and it's a hospice patient, and I'll say, what's the goal blood pressure? And they'll start quoting JNC 97, whatever's the latest one. And I'll say, you know, this guy's pretty sick. He's probably going to transfer it to the eternal care unit in about a month. Are you going to stick with 120/80? And then they kind of like, oh, maybe 130/85. I said, you know, he might not even last a week. Well, 140/90, but we really don't have tremendous guidance. I will share with you later what there is to look at. But again, thinking of all these considerations. Approaching the entire medication list. There are so many tools that are out there. I like MedStopper. I really like Stop Frail, which I'm going to show you on the next slide. Next slide also, by the way, approaching the entire medication list. I'm sure everyone has heard of the Beers list. There's one called DPharm. There are several that are out there. So this looks at the whole medication list, and it helps you identify and prioritize the medications that should be deprescribed. I do think prioritization is important because I try, unless it's really somebody's taking Tums and a vitamin C and a multivitamin, then you can stop all 3 of those at one time. But generally, if you stop more than one drug at a time and they have a flare in their symptoms or they have some adverse outcome, how do you know which drug to blame and which one to restart? So that's important. So at this level, when you're looking at the whole medication regimen, you're weighing the benefits and harms of the medications and considering, is this medication helping the patient achieve their goals of care? And of course, we always have to consider the benefits and the burdens of drug therapy. And a lot of these tools have a stepwise approach or algorithm approach. Next slide, number 13, Stop Frail version 2. So I'm sure you've all heard of the stop-start criteria, which is aims more at older adults and, you know, which medications we should think about stopping and also which medications we should maybe start in somebody usually for like cardioprophylaxis and so forth. Patients who are at the end of life. So they have, the first category is just in general. So any medication that a patient is not taking consistently, if they're not taking it consistently, maybe they don't even need it, or there's really no clear clinical indication, or symptom, but now the symptoms all better. And then from there on, categories B through J are broken into the different body systems, as you can see. So when you have a patient with a cardiac history, do we really need the lipid-lowering drugs, antihypertensives, anti-anginal? And it's not saying these should automatically be stopped, but it gives you a series of questions to ask yourself. Certainly, if someone's taking a statin for primary prophylaxis and they're in my hospice, we're definitely going to stop it. Antiplatelets and aspirin, the CNS drugs, GI, and so forth and so on. Next slide, 14, medication-specific tools. I love this website. I think it's actually is out of Canada, so it's pretty cool, dprescribing.org. They have wonderful, wonderful guidance on their website. If you look at this is the front of like a little pocket card, and this one is looking at anti-hyperglycemic deprescribing. And if they have these for proton pump inhibitors, the anti-hyperglycemics, antipsychotics, agonists, and cholinesterase inhibitors and memantine. And then on the back, they have additional information. So you can print it out in color, you can laminate it, drag it around with you. I think they're really excellent. And they provide extensive literature backup on their website for your perusal. Next slide, 15. We're going to talk about metabolic syndrome. Going right on to the next slide, it says metabolic syndrome. What the heck is metabolic syndrome? It is a cluster of risk factors that raise the risk of heart disease, diabetes, stroke, and other health problems. According to the American Heart Association, about 1/3 of all adults strolling around have metabolic syndrome. Next slide. So technically, to be diagnosed with metabolic syndrome, you would have to have 3 of 5 risk factors as promulgated by the National Cholesterol Education Program Adult Treatment Panel. So they define it as central obesity, defined by the waist circumference. So if you're built like an apple, that's what you're looking at, plus 2 of the following 4. Either increased triglycerides or you're being treated for hypertriglyceridemia, reduced HDL or being treated, increased blood pressure or treatment, or raised fasting plasma glucose or previously diagnosed diabetes. So again, the central obesity and 2 of those 4. Next slide. Now let's meet Mr. Herndon. Poor Mr. Herndon, he's a 76-year-old man admitted to hospice with stage 4 non-small cell lung cancer. According to his oncologist, his prognosis is about 4 to 6 weeks. He has comorbid conditions of type 2 diabetes, hypertension, chronic kidney disease stage 4, dyslipidemia, an 80-pack-year history of smoking, although he did stop a year ago when he was diagnosed with lung cancer. Here, next slide, is his medication history. He's been taking atorvastatin for his dyslipidemia, metformin ER, 1,000, 2 tabs for his diabetes a day, Lantus insulin, 20 units at bedtime, and Novolog as a sliding scale. I hate sliding scale insulin, 4 times a day. The lisinopril and the amlodipine 5 milligrams, both pretty low doses for his high blood pressure. The obligatory multivitamin with iron, acetaminophen extended release 650 2 caps Q8, which still keeps him under 4 grams. MS Contin, which is a long-acting oral morphine, Q12, and Roxanol, which is an oral morphine solution, 20 milligram per mil, Q2 PRN, and Senna. So I think we've got some wiggle room here in looking at this medication regimen. So Mr. Herndon is 5'10", he weighs 165 pounds, but he has lost 100 pounds since he was diagnosed a year ago. At present, his waist circumference is 34. So I'm not so sure he has metabolic syndrome any longer. And interestingly, I'm on the next slide, by the way. I hope you're seeing Mr. Herndon here. He rarely, if ever, uses the sliding scale Novolog insulin. I personally think poking your finger 4 times a day is not a very palliative intervention. And in addition, he complains symptoms occasionally. Now in hospice, we're not going to draw an A1C, but we did get this data from 6 months ago, and it was 6.9%, which is below the goal and even a little on the low side for an older adult. And when he's seated, his blood pressure is 120/70. He says he feels woozy. Next slide. When you suggest slimming down his medication regimen, he gets very upset and cries, "What? My heart doctor and my regular doctor said I had to stay on these medications till the day I die. Are you saying I'm going to die tomorrow? You young whippersnappers always want to upset the apple cart. So, young whippersnapper, what are you going to do about this?" Let's go to the next slide. Let's look at these drugs. So the multivitamin with iron. Now, I personally would get rid of all of these. I know that generally speaking, we say people don't need a multivitamin unless their diet is very poor. I mean, he has lost 100 pounds. I worry more about the side effects of a multivitamin with iron, notably nausea. But if he is like on fire to keep this multivitamin and it's not worsening his constipation or making him nauseated, I worry also the iron is going to make his stools dark, which then we don't know if he's bleeding internally and he's on an anticoagulant. Oh, but that's unlikely. So if he's like, I really want to keep my multivitamin and it's not causing problems, okay, we'll save that fight for another day. Next slide. How about the analgesics and the laxatives? So From what I've heard and read in the Netherlands, when someone has cancer, at least this used to be true, they would automatically get 4 grams a day of acetaminophen, and even regardless of how much opioid they were getting. So I remember thinking, there's got to be a line in the sand where the acetaminophen is not really bringing anything more to the table over and above the opioid. So actually somebody did research this, and it turns out it's about 60 to 70 milligrams a day. So when people were on like 60 or 70 of morphine a day or 40 or 50 of oxycodone, they could not tell the difference with or without acetaminophen. So I will admit, though, that sometimes people are taking an opioid for some kind of visceral pain, and maybe they get a tension headache, and the acetaminophen is a better drug for that. So that's a different story. But I mean, again, if the patient really feels like it's giving them relief, maybe you are having a small opioid sparing effect, I would just consider, do they have liver disease or any history of alcoholism? So of course, you have to ask yourself, is the morphine controlling the pain? And is the Senna sufficient to maintain bowel function? Next slide. So again, I mentioned this before, the words of the day: time to benefit, which is defined as the time to significant benefit observed in trials of people treated with the drug compared with controls. And the other, as I said, is legacy effect, treatment effects that persist or emerge at some time after the treatment trial ends. Next slide. Let's look at hypertension, a silent killer. So what is the goal blood pressure? The question I always ask my little pharmacy students. The American College of Cardiology and Heart Association in 2017 said less than 130/80, including people over 65 who are ambulatory and community dwelling. The European group and the UK group say less than 140/90. The UK NICE guidelines say less than 150/90, though, if they are fit patients 80 or older. And the American Cardiology crew says if your systolic's less than 150 for adults over 60, or less than 140 with a history of CVA, cardiovascular risk. I will mention one thing here too. Prescribers in the US seem to be fond of writing an order when the patient's on a beta blocker like metoprolol. Let's say somebody's on metoprolol 100 milligrams a day. They will write an order like hold for a systolic less than whatever, 90, or hold for a diastolic less than, say, 60. So basically, they want the patient to check their blood pressure every day and then make a decision of whether they take it or not. I personally think it's a bad idea to play peekaboo with a beta blocker. Like today, I'll take 100. I'll take 100 for 5 days in a row, and then I'm going to skip it for 3 days. Wouldn't it make more sense just to reduce the dose of the drug? What is the time to benefit in treating hypertension? It takes 2 to 5 years. And is there a legacy effect? We have seen 37% of patients remain normotensive 6 months after stopping therapy. 26% of patients at 2 years. That's amazing. And we know that blood pressure trajectories in the last 14 years of life kind of continually decline. Next slide. Be careful of prescribing cascade. This is so important. This is where you see people needing drugs to treat drug-induced effects. So, for example, this patient is on amlodipine, but amlodipine or felodipine can cause pedal edema. So then the prescriber orders a loop diuretic like furosemide, bumetanide, torsemide, and then that causes electrolyte derangements or they develop incontinence. And now you have to have maybe a potassium, maybe a magnesium supplement, and then they may start one of those anticholinergics for incontinence. Next slide. What do the guidelines say? So I'm not going to beat this to death, but all the guidelines say, you know, maybe it should be, the blood pressure goal should be a little bit higher, certainly avoiding some drugs, in particular for older adults like the alpha-1 blockers, the centrally active alpha agonists are important. The European group says if somebody has a prognosis of less than 3 months, diuretics outside of the loops maybe are questionable. Don't really start these other drugs like ACE inhibitor, ARB, and so forth. Questionable value for the rest. I do think if someone has heart failure, this is a common clinical thing we see. If someone has heart failure, they're on a bunch of drugs for their heart failure and their blood pressure is starting to tank. So we will peel things off and we do follow an order. We look at comorbid conditions and importantly, if someone is retaining fluid, the diuretic would be the last to go because people really feel icky when they're retaining fluid. The next slide, pulling the trigger. So again, as I just said, you want to evaluate comorbid conditions, like if the patient also has AFib, maybe keeping the beta blocker or the non-dihydropyridine could be beneficial, or heart failure, ACE inhibitor, or probably the loop's going to be the last to go. You want to gradually withdraw the beta blockers and the centrally acting alpha agonists. I tell the nurses I work with, if you can't remember for every drug, whether you can stop it cold or you have to taper, as a general rule, anything that messes with your head or your heart, I would probably taper. Again, very important. I think most people don't even think about this, monitoring for withdrawal effects. So with beta blockers, you can see angina, anxiety, MI, palpitations, the centrally acting drugs, agitation and headache and palpitations. And again, what target a blood pressure that's reasonable, like 150/90. And symptoms are unlikely, even with a blood pressure up to 180/100, 110, but we don't certainly want target organ damage. Next slide. So how do we have this conversation with Mr. Herndon? For one thing, he is having side effects right now from his regimen. His blood pressure is low normal, and he's complaining of orthostasis. So which one should we stop, the lisinopril or the amlodipine? That's a consideration. Plus, he's lost 100 pounds, so his blood pressure has naturally declined. So I say, let's stop the amlodipine. It's only 5 milligrams. That's not very much drug. And then we'll reevaluate. And I would bet the farm that chances are good in a few days we can reduce the lisinopril to 5, and then probably in a week or so may be able to stop that as well. But you have the conversations that you have with the patient and the family, critically important. So reassure the patient. Next slide. Look at the slide of cheeseburger and fries. Who's hungry? Who's with me? I don't care about no stinking cholesterol. Next slide. Dyslipidemia certainly increases the risk for ASCVD, whether it's cardiovascular, cerebrovascular, or peripheral vascular disease. And we do know that statins or other drugs can slow or prevent the atherosclerotic disease process. And the goal of therapy is to prevent morbidity and mortality, as listed here. What's the time to benefit? A year or longer. I will say it is shorter following an acute coronary event. I will skip to the end here. When we have a hospice patient who comes to us on therapy for dyslipidemia, and they've had a heart attack or a stroke in the last 6 months, we would try to continue that therapy. It was published, and there's this beautiful Kaplan-Meier graph showing people who were on a statin before their heart attack and then took it right after their heart attack. People who were on it before but did not resume it, people who were not on it before but did start after their heart attack, or people who were not on it before and not on it after, and they track survival. And it was just as you would expect. The people who had always been on it and continued were highest. People who had never and then did not take it were the worst case scenario. So we can generally see 2 to 5 years for MI protection, 2 years to impact all-cause mortality, and 4 to 5 years for stroke prevention. A recent meta-analysis showed a legacy effect on all-cause mortality and cardiovascular in coronary prevention. Next slide. Atorvastatin. I'm sure everyone has heard of this study by Jean Kuttner. She looked at almost 400 patients who were within a year of death, where their physician said, in answer to the surprise question, I would not be surprised if they died within the next year, and they were taking a statin. So they were randomized to either continue or stop their statin. A lot of people criticize this trial, saying, oh, your N wasn't big enough. Well, as far as I'm concerned, this is a real world study. I mean, this is really looking at what do we care about. So their outcomes were, the primary outcome is the rate of days, and there was no statistically significant difference. So those who stopped the statin, 20% died at 60 days with a median time to death of 229 days. Those who continued the statin, this is interesting, a little bit more died by 60 days, and they had a shorter median time to death, although those were not statistically different. And then this is important, 8 years after the study that had evaluated the impact of atorvastatin. There's a study about the impact of atorvastatin. When they stopped the study, they looked 8 years later, and the patients who had been taking atorvastatin 8 years prior still had fewer deaths from cardiovascular and non-cardiovascular disease. Next slide. The guidelines, again, I'm not going to read this to you, but they're all fairly consistent to loosen the reins a little bit. Next slide. So bringing on primary prevention, we see conflicting information 5 or older. Generally speaking, it's okay to discontinue lipid-lowering therapy in patients with a life expectancy less than a year or 2. Secondary prevention, this is different. They've already had an event. The time to benefit is earlier in lipid-lowering therapy, and to probably continue the statin or whatever they're on if they've had a recent acute coronary syndrome, stroke, or TIA, or if they have unstable symptomatic disease. So at some point, the patient is going to lose the ability to swallow. and then we would stop the medication. So you can stop these bad boys abruptly. Next slide. So how do we have this convo with Mr. Herndon? Mr. Herndon, kudos to you for taking atorvastatin all these years. Clearly, it's been providing you benefit because you've not had a heart attack or a stroke. But the good news is that research has shown that the benefit you accrued from taking atorvastatin all those years was like putting money in the bank. And even if we discontinue the atorvastatin now, you will continue to reap the benefits. Research has further shown that there is not an increased risk of a heart attack or stroke for people clinically similar to you. And while they don't really cause major side effects, certainly there's the myopathy to worry about, it would be one less tablet you have to take, and you'd have less risk of side effects such as muscle weakness. Next slide. So what about his diabetes? Well, I think my title of this slide gives away my position on this. Go get the donuts and the sweet tea. So diabetes, as you know, is growing in prevalence. In the US in 2019, 37.3 million people were diagnosed with diabetes. And of those, only 28 million knew that they had it. So there are a lot of people walking around with type 2 diabetes undiagnosed. When you look at older adults, the percentage of Americans age 65 and older, it's about 29.2%. And probably if you look at glucose intolerance altogether for older adults, it's about 50%. So not an inconsiderable problem. Next slide. I am very excited about the DCCT trial. This was a trial done in the early 1990s, looking at patients with type 1 diabetes. They were divided into two groups, those who had tight blood glucose control, and the other group had usual blood glucose control. What does this mean? The tightly controlled group either had multiple daily injections of insulin or they had an insulin pump. And they talked to their healthcare team every week. And the usual control at that time was probably split mix, regular NPH twice a day, and they saw their healthcare team every 3 months. And within those two groups of tight control and usual, they further subdivided them into no complications and early complications, as shown by nephropathy and neuropathy. So when they looked at the group that had tighter control, they had a 40 to 60% reduction in the development of complications. And those who already had complications, they had much slower progression. That was pretty exciting news. We were very excited. That actually was the first data we had to show conclusively that tight blood glucose control does have an impact on complications. Now, you notice I didn't say anything about macrovascular complications, like it's heart attacks and strokes and so forth. So they looked at these people 17 years after starting the DCCT trial. Now, everybody has pretty much on average the same blood glucose control, but those people back in the day who had been in the tight glycemic arm, now we're looking at macrovascular events. They had a 42% risk reduction in any cardiovascular event and a 57% reduction in non-fatal heart attack, stroke, or death from cardiovascular disease. So pretty impressive. Next slide. What does the ADA say? They talk about if someone's healthy, for older adults, few coexisting chronic diseases, and they're intact, both cognitively and functional status. Instead of saying less than 7 for the A1C, they're saying 7, 7.5, a fasting somewhere between 80 and 130. Then if the patient gets a little more sick, less than 8, and then maybe 90 to 150. And if they're really sick, they say, don't even worry about the A1C. Just avoid the symptoms of hypoglycemia and hyperglycemia, and a fasting between 100 and 180 is fine. I'm actually okay with the fasting or blood sugar, even if it's random, of like 250 if they're asymptomatic and they're very close to the end. I think if you are trying hard to die, go get a milkshake. Next slide. I'm not going to read this, but this is from the American Diabetes Association showing when you should be more stringent with the A1C and less stringent. Next slide, please. And again, deprescribing.org has a lovely front and back card on anti-hyperglycemic deprescribing. So you might want to take a look at that. Next slide. So what are we going to do with our Mr. One? He has had diabetes for many years. What is he on? He's on metformin XR 1,000 milligrams, 2 tabs per day. He's on Lantus insulin, 20 units at bedtime, and Novolog sliding scale 4 times daily. So metformin. Mr. Herndon has chronic kidney disease stage 4, which is a creatinine clearance between 15 and 30. Metformin is contraindicated. So I really am happy that the FDA went to a creatinine clearance based system for guidance for metformin instead of just a creatinine. So we're going to get rid of the metformin. Now the Novolog sliding scale, he's not using it, but he's poking his poor finger 4 times a day. I think let's just get rid of it. And then what about the Lantus? So maybe we should see how we do with stopping the metformin and the Novolog. And then once the dust settles from that, we can see what will we do with the Lantus. Next slide. So what does this mean for Mr. Herndon? So all those years he watched his diet, took his medications, and monitored his blood glucose. Again, he was putting money in the bank. Now we can loosen the reins a bit and he can draw his dividends, secure in the knowledge that his risk of diabetes-related complications is extremely low. And we will monitor him for signs of hyperglycemia and, of course, hypoglycemia. Next slide. So what about the Lantus? So we've agreed we're going to stop the metformin and the Novolog. Now let's have a discussion about how often you should check your sugar. How about if we back it off and say, why don't you just check your fasting on Monday, Wednesday, and Friday? And even if it's up to 200, if you're asymptomatic, that's okay. And then maybe we can lower the dose of Lantus or maybe even stop it at one point. But again, I think poking yourself 4 times a day is not very palliative. Next slide. So the conversation, Mr. Herndon, you deserve an enormous amount of credit for following your diet and all your diabetes medications for all these years. And like the statins, research has shown that tighter blood glucose control, starting at the time of diabetes diagnosis, leads to an accrued benefit in reduction of complications later in life. You're not even using the Novolog because your blood sugar isn't high enough and you've lost a lot of weight or you're not eating like you used to. Next slide. Given that you have kidney disease, we really should stop the metformin so you don't have side effects. Let's stop the metformin and the Novolog. We'll follow your blood sugar over the next week or so, and then we'll decide what to do about the Lantus. In the meantime, we can liberalize your meal plan and stop checking your blood glucose so frequently you have earned it. Next slide. So this is just I always show this slide to my students because they are quick to say, well, they're dying. What does it matter? That's not very sensitive. So obviously, option D, we'll take a look at each of your medications, and you and I and your family will discuss this with your doctor and make these decisions. Next slide. Alrighty, that takes care of metabolic syndrome. I'd like to spend a good 5 to 7 minutes on Alzheimer's disease because we use an awful lot of these medications. Next slide. Alzheimer's disease, I know you've heard several people speak on this already, very common cause of dementia. We know it's a relentlessly progressive neurodegenerative disease with worsening memory, declines in language, and so forth. Survival is about 4 to 8 years. So the functional and cognitive decline and maximize symptom control and quality of. So the treatments, again, non-pharmacologics. And I just saw a thing on TikTok the other day about how physical activity is so important, particularly strengthen your legs and strengthen your hands in case you lose your balance and you can catch yourself better if your hands have good grip strength. But also cognitive training. I mean, maybe that didn't rank right up there as highest on the list, but who doesn't love a good Sudoku puzzle? And certainly managing comorbid conditions. So what do we have at our disposal? We have the cholinesterase inhibitors, donepezil, ribostigmine, and galantamine. We have the N-methyl antagonist, memantine. And in the US, at least, we have the combination. And we have the new drug now, which has caused quite the little stir. Aducanumab. It's a monoclonal antibody, and people are very upset that this got approved by the FDA. And it wasn't really based on clinical outcomes. So the FDA is mandating the drug company do those trials now. Next slide. So here we have poor Judy, a 78-year-old woman. She's been falling a lot. She has breast cancer, hypertension, dyslipidemia, NVAF, Alzheimer's. She's a fast 7C. She lives with her daughter, Laura, in Maryland, and her son, Frederick, is a lawyer who lives in California. So I live in Maryland, coast of the United States, and that's always the case, that the other adult child generally is on the West Coast, and they're always a doctor or a lawyer, and they're always very opinionated. And I'm very tempted to say, you know, instead of telling us what to do from 3,000 miles away, why don't you take care of your mom? But that's just me. Next slide. So Judy is taking donepezil, memantine, lisinopril, atorvastatin, warfarin, multivitamin, iron, and calcium, and vitamin D. This is like every hospice patient that we get. So when you suggest slimming down on the meds, Laura's on board, but Frederick goes nuts and her off. Any issues here? I should say so. Next slide. So the cholinesterase inhibitors, they're generic now, so they're not that expensive, but the cholinesterase inhibitors are indicated for mild, moderate, and some cases severe dementia, and the memantine is for moderate to severe. Next slide. So you all know the FAST criteria. To get into hospice in the US, you have to be a FAST 7. Next slide. This is the study everybody points to say, see, these drugs do work in moderate to severe dementia. So let's take a look. Howard and colleagues looked at almost 300 community dwelling, moderate to severe Alzheimer's disease patients treated with donepezil for at least 3 months. So coming into the study, they had mini-mental scores between 5 and 13, and then they followed them for 52 weeks. They stratified them by study center, because this is a multi-center trial, how long they've been getting donepezil prior to the trial, which is 3 to 6 months or 6 months or greater, their baseline mini-mental of 5 to 9 versus 10 to 13, and their age. So people were randomized to either donepezil alone, memantine alone, both drugs together, or just placebo plus placebo. Next slide. I like their outcome. They looked at the mini-mental state score, and they decided that a clinically important difference was scoring 1.4 points or greater higher than the comparator. And we've all had families say, look, I know her cognition is shot, but she's easier for me to handle when she's on these drugs. So Howard and colleagues said, alrighty, we're going to use the caregiver rated Bristol Activities of Daily Living scale. And they said a clinically important difference was scoring 3.5 points or greater lower than the comparator, because the lower the score, the better the patient is. So what did we see? Next slide. So we're looking at donepezil and memantine for moderate to severe. I've reminded you of what are the clinically important lines in the sand, so to speak. When they looked at everybody who got donepezil versus everybody who did not, that met the mark for clinical importance using the mini-mental state exam. The BADLS did not make the mark at all, whether it was the donepezil people or the memantine people. And when it was just memantine, not make the mark for clinical importance, looking at the mini-mental state exam. Next slide. Now, this is very important. This is where they said, you know how we did the sub-analysis of people who came into this trial with a mini-mental between 5 and 9 versus 10 to 13. So when they did that, because we've already voted memantine off the island, so now we're just looking at the mini-mental state score for the people who had donepezil. If their mini-mental was between 10 and 13, it was 2.6, and it absolutely met their requirement for clinical importance. But the people who were 5 to 9, they did not. They did not. So only people with a mini-mental score of 10 or higher met the mark. Next slide. I love this slide. This slide was done by Riceberg, the dude who came up with the FAST criteria. If you look at the second line, GDS and FAST stage, all the way to the right, you can see stage 7, which is what our patient is. If you go to the bottom, the next to bottom row is the mini-mental state score. So he's saying, once you're a FAST 7, you probably have a mini-mental of 0. I don't know if that's true or not. Maybe they'll get a couple of points, but you know what they're not? They are not 10 to 13. So I think this is pretty good evidence that, we probably can let these go. Next slide. Adverse effects. Memantine is not too bad, but you can see side effects. The cholinesterase inhibitors, a lot of nausea, particularly that 23 milligram donepezil. That's awful. So a lot of GI symptoms, insomnia, fatigue, muscle cramps, and they do carry a warning. Cholinesterase inhibitors may have vagotonic effects on the SA and AV nodes, manifesting as bradycardia or heart block. And you can see, if you look at hospital visits for syncope, bradycardia, pacemaker insertion, and hip fracture, absolutely, it's higher in the people taking a cholinesterase inhibitor as opposed to the controls. Next slide. So, in my humble opinion, the bottom line for the dementia drugs is I think they are less helpful and more harmful in advanced disease. I do not think they should be used in FAST 7 or provided by the hospice unless there's really clear and ongoing benefit. It gets a little stickier when we have a patient admitted to hospice with lung cancer, and they also happen to have Alzheimer's disease. Maybe it's a FAST 5 or a FAST 6. So that's more of a case-by-case decision. And if you're going to stop these drugs, I would taper. For one thing, you don't want to have a recurrence of any symptoms, although we're going to be monitoring like crazy for that. And also to show the family that in all likelihood, the patient is not going to have an exacerbation. Next slide. But is Frederick buying what you're selling? Next slide. No, he is not. So this is a nursing protocol for having conversations about bad news, where it's setting, perception, invitation, knowledge, emotion, and summarizing your recommendation. Next slide. And this just goes over the spikes protocol. So having a confidential private area to have the conversation, asking what they already know about the situation. So we could ask Frederick, what do you know about these medications? And he'll probably say, well, it slows the progression of the Alzheimer's. That's true. And then the invitation, how much do you want to know? Can I share some information with you? And then the knowledge is giving them that information. And generally, when you lay this bomb down of, your mom's had Alzheimer's for several years now, and you tell me a year ago she knew who you were and she could walk up the stairs by herself. So despite taking these medications for the last year, she has continued to decline. Do you see that as well? Then they may have an emotional response. And, you may or may not agree with their emotional response, but at least acknowledging it and being empathetic. I can see that you're very upset by this. And then strategy and summary of what we're going to do. Next slide. I'm not going to read this, but this is the guidelines. I do like the deprescribing.org, which is the same as the Australian guidelines because that's where it came from. Next slide. So again, this is the information. If you go to the University of Sydney, they've done some excellent work here. Next slide. And this is their little front and back card that you should take a look at. Next slide. So in conclusion, deprescribing is part of the prescribing continuum. Have a new patient. You're going to evaluate them. You're going to think about variables about that patient and medication-specific variables and select the best drug for that patient. You're going to try the drug. You may titrate the dose. You're going to see how they do. And then if you look to the far right, you either continue the drug because you're meeting your goal or you stop it. So we have to always weigh the benefits and burdens of drug therapy in all patients, but especially in advanced or serious illness. And the conversations are very, very important. So I don't have time to do anticoagulation, but you have the slides. I'll give you the Reader's Digest version. For venous thromboembolism, I think it's a case-by-case decision. Depends. Are they symptomatic? How long ago was it? And then if it comes to atrial fibrillation, I've given you this reference. This is an open access journal. It's the use of antithrombotics at the end of life, an in-depth chart review, Creative Commons license. So I was able to use this diagram, but this image right here is the keys to the kingdom. It's a critical thinking process. What do you do with these drugs for somebody, for example, whether it's an anticoagulant or an antiplatelet, somebody with AFib? This is amazing. So that concludes my presentation. Thank you.
Thank you to both our speakers, and apologies for all the technical hiccups that we were experiencing. I've got a few questions online, but we only have 3.5 minutes, so apologies. I think that gives us 2 questions. So first question is, how would you suggest we incorporate capacity assessment within a palliative care assessment? Dr. Moorhouse, yeah.
So I've seen so much variation in the degree to which palliative care groups and divisions and departments engage in goals of care conversation where we're trying to sort out the sort of balance of treatments for cure and rehabilitation versus treatments directed solely at comfort and getting that correct mix. I think that any time a patient is being asked to make major decisions about how we're managing their disease, we need to ensure, and it doesn't need to be a formal capacity assessment, but just we need to ensure that their understanding of their disease is accurate and that they have an appreciation of what the risks and benefits are. And I always remind students that when you're assessing capacity, you can keep the stakes low, keep it limited to their capacity on this day to make this decision. And we don't have to sort of broaden it to sort of all medical decision making or beyond medical decision making. I hope that started to address your question.
Thank you. The next question for our other speaker is, are there any tools to help with decision making on deprescribing anticoagulants, e.g. the has-bled score as an example?
Yes, that's a great question. And if I'd had more time, I have slides on that. My resident last year actually did a study looking at people who got a palliative care consult or were admitted to hospice, and she calculated the CHAD-VASc and the has-bled score, and they were pretty much equal. So it's 50-50. And then when you look at the CHAD-VASc and if you have all of the risk factors, all 12 points, all the points, it's about a 12% chance of having a stroke per year. But then when you look at hospice, where our median length of stay is 17 days, the risk is minuscule. So, and then if they're on an anticoagulant, it cuts it by 2/3. So I urge you to take a look at the last slide in my deck, which talks about risk assessment and so forth in atrial fibrillation. It really is excellent.
Thank you so much. And I don't think we've got any time for any additional questions, but just to let everybody know that the slides from all our speakers will be up on the system shortly. Thank you so much. Thank you.
Thank you.